Okay.
Sikin already postponed.
Okay. Good afternoon, everyone. Today is my turn for a journal sharing. I will share about the systemic review which published in 2024 regarding the dexmedetomidine pharmacology in the pediatric patients. So this is the article that I'm going to present. So why this topic important? Because in our PICU setting, we commonly start some sedations. Example like opioids, benzodiazepine, and also dexmedetomidine. So why Presidex is favored because of the safety profile and also cognitive profile. Especially nowadays, we try to avoid the benzodiazepine, because it may cause some neurotoxic. Then from the SCCM 2022, they recommend that Presidex should be used as the first line agent for sedation in pediatric post-operative patients with expected early extubation. So for the PDA wise, for pediatric, it's approved only for the short non-invasive procedure, for example, like MRI. And it's not approved for continuous or procedural sedation. So, but in real, Presidex is widely used in our PICU, NICU, or CICU setting for procedural and also long-term sedation. Reason why we like it so much because it can induce a natural sleep-like sedation, and also the we believe has the analgesic sparing effect. But what's the challenges is the recommended dose for the continuous infusion, it's ranging from 0.2 to 1.5 mic per kg per hour. Because of the highly variable pharmacokinetics, so in pediatric age groups, so we have no idea about what's the accurate dosing that we supposed to start for our patient. And also no standardized titration. So with this, there's a risk of the over or under sedation. And we also have limited data on the dose response, safety, and also adverse events of the Presidex. So for the pharmacokinetics overview for pediatric age group, the volume of distribution is lower compared to adult, which for pediatrics 1 month to 17 years old, it's about 0.8 to 1 liter per kg. So when lower volume of distribution, meaning that the drug concentration will rise faster, so sedation may occur at the lower doses. And in terms of the clearance, it's higher compared to adult. For pediatric, it's about 0.9 to 1.2 liter per kg. So this is because children has the high liver blood flow and also metabolic activity per kg. So drug tends to clear faster and sometimes may need higher or more frequent dosing to maintain the effect. So in terms of the metabolic pathway, it's primarily hepatic metabolized in liver via the enzyme like UGT2B10 or UGT1A4 and also CYP enzyme. So for neonates and infants, they have the immature UGT and also CYP enzyme system. So that tends to clear slower, and there's a potential for the prolonged sedation when used the Presidex. That's the reason why age-based dosing adjustment and monitoring are important. So we also would like to discuss about the pharmacogenomic variability. So it's believed that when there is a polymorphism in the metabolic enzyme, it may affect the pharmacodynamic of the Presidex. And the target receptor for Presidex is the A2A adrenoceptor. There are 8 known genetic variants reported, and it may alter the receptor sensitivity and subsequently affect our pharmacodynamic response. And we studied the sedation effect and also hemodynamic stability for the patient. So this article integrated the pharmacokinetics, pharmacodynamic, and also pharmacogenomic modeling. It allowed the analysis of the body weight, age, and also genetic polymorphism to determine the outcome of the drugs. For pharmacokinetic-wise, they focus on the clearance and also volume distribution. And for the pharmacodynamic, they look into the sedation score and also hemodynamic effect, includes the heart rate and also blood pressure. The aim of this journal is to identify the patient-specific predictors for personalized dexmedetomidine dosing to improve the dosing precision and also the sedation safety and efficacy. So the method for this journal is by using the literature search and selection. So they search through the 2 main database, include the PubMed and also Ovid, and they use the terms of dexmedetomidine, pharmacokinetics, pharmacodynamics, pharmacogenetics, and also pharmacogenomics. They use the manual review of the reference list from the included studies and reviews. The last search was in May 2024. So this study, they included the controlled trials, cohort study, case control studies in pediatric patients which age between 0 to 18 years old. Then they've divided to 2 models, which are population pharmacokinetics and also physiological pharmacokinetics. Because for the pharmacokinetics and pharmacodynamic studies, they selected the reference after 2017. But because of very few studies for the pharmacogenetics, so the search, they included the articles from 2011 onward. Exclusion criteria are case report, meta-analysis, reviews, and conference abstract, and also the non-English language paper. So from their search, they included 26 studies which met the inclusion criteria. So data extracted and verified by 2 independent reviewers. So, sorry. So for the first model, which is the population pharmacokinetic studies, what we know now is Presidex dosing is a weight-based, but however, in young children less than 3-year-old, pharmacokinetics are highly variable. So, what are the important factors that may affect the pharmacokinetics are the age and also organ maturation, because it will influence the drug clearance and also the weight of the patient, which will determine the distribution and also metabolism of the drugs. So for this population pharmacokinetic studies aim to model how the age, weight, and also other factors influence the dexmedetomidine pharmacokinetics. So for this model, they included 8 studies. So the first, they quote the Moss et al. So from these studies, they mentioned that the clearance actually increased with age, which those prediction for neonate for the roughly estimate weight of 3.6, they will need the 0.77 mic per kg per hour to achieve the plasma concentration of about 1 nanogram per mil. So this is for the procedure sedation, because with the plasma concentration of about 1 nanogram per mil, they believe the patient will achieve moderate or to deep sedation. So when they study about the 3-year-old children, they noticed that the patient will need about 1.04 mic per kg per hour to achieve the same plasma concentration of 1 nanogram per mil. And interestingly, after 3 years, they think its inverse relationship, which the larger size has a relatively lower clearance per kg. So this was further confirmed by the Dismal et al. So from this study, they conclude that the main predictors, age is the strongest covariate for less than 2 years old patient, and those that 2 and more, then weight will determine the pharmacokinetics of the PCDEX. So they support the combine with both the age, organ maturation, and also the weight for the adjustment for the PCDEX dosing. So other than that, there are 5 different studies using the only pediatric data confirm that the weight strongly correlates with the clearance and also plasma concentration. Age effect diminishes as the child grows, as they believe when around 3 years old, the organ maturation should be reaching the plateau state. So for pediatric dexmedetomidine, pharmacokinetics is shaped by both age and also body size. For less than 3 years old, they think the age and organ maturation dominates, but like more 3 and more, 3 and after 3 years old, the weight will determine the pharmacokinetics of the patient. Then another study from the Burr et al. That included 26 covariates, which includes pharmacodynamic, hemodynamics, and also sedation score. So interestingly, they noticed that noradrenaline significantly reduced the clearance. This is because NORAD gives the cause the vasoconstriction, which reduce the liver blood flow. So that's the reason why they have the lower clearance when the patient on NORAD. But this study is small sample size, has small sample size. Then for second module, which is the physiological pharmacokinetic studies, they included 10 people. They used the method of the plasma drug sampling, vital sign, lab monitoring, and also pharmacokinetic modeling to determine the outcome, to determine the pharmacodynamic of the PCDEX. So they look into the sedation depth and responsiveness, and also safety about the is there any incidence of bradycardia, hypotension, or delirium when patient on the PCDEX. And for this model, they further divide to 3 main domain, which are procedural when the PCDEX used as a procedural sedation, as a continuous sedation in PICU, or pharmacogenomics, and also pharmacogenomics. So for this first part about the procedural sedation, Shim et al. Conclude that surgical physiology will alter the dexmedetomidine, because what they found during the pulmonary bypass, the drug distribution will expand into the third compartment. So those that on bypass, the plasma concentration will dropped significantly, the p-value less than 0.016. It caused by the altered blood flow and also capillary permeability. So when the low plasma concentration will lead to the low sedative effect, and they frequently need the dose adjustment, and oftenly they need higher dose compared to the patient compared to the patient that not on bypass. Then for the this study also study about the impact of the sedation and analgesia requirement when the patient on Presidex. They noticed that it will reduce the intraoperative benzodiazepine and also opioid use. So for this study, they use higher Presidex dose, it reached about cumulative dose about 12.5 sorry, 5.8 to 12.5 mic per kg over 48 hours. With this, right, they noticed no increase in adverse event or usage of the volatile anesthetic dose. So they think with the short exposure and the higher dose of the Presidex use actually reduce the requirement of the benzodiazepine and also the opioid use. But there is some increase in the propofol and also PCM, but it's not statistically significant. Then they also study about the Presidex, whether it's a renal protective or not. So Joe et al. They compared the usage of the Presidex with the and saline during the pediatric surgery. They noticed that it reduced the incidence of the post-operative AKI, increased the estimated GFR, but no difference in the pressor support or hemodynamics, and no diuretics used during the or after surgery. This is because they think Presidex is useful to reduce the sympathetic tone, which reduce the inflammation. So it's possible renal protective effect. But subsequently, a year after that, Kim et al. Study this study has a larger population, which about 139 patient sample. They noticed that it's no significant difference in AKI or major outcome. Presidex group had slightly reduced in terms of the creatinine and also slight increment of the GFR. But between these studies, the difference is the Kim et al. Actually included the younger age patient, and also the loading dose actually higher compared to the Joe et al. So in conclusion, it's weak but possible renal protective effect, and each and dose may influence the response. Then, thirdly, the study about the post-operative jet, whether Presidex reduce the incidence of the jet. So from this study of the Kim et al. In 2023, they conclude that no difference in the post-operative jet or arrhythmia incidence between the Presidex and also the placebo. But a year after that, Hassan, they compare with 3 groups in congenital heart surgery. So group C, which control group, has the incidence of jet incident about 30%. From group D, with only Presidex, jet incidence was about 10%, but with the combination of Presidex and magnesium, it significantly reduced the jet incident to 2.5%. So, and other than that, they noticed shorter CICU and also hospital stay. It's because Presidex is a central sympatholysis. It reduces the catecholamine surge, and at the same time, when used together with magnesium, it adds the effect of the membrane stabilization. Then, how about the patient that with liver failure? So from this Damian et al., they include the sample, the patient between 1 month to 18 years old, those that post liver transplant patients. They study about the Presidex clearance. So their finding include post transplant INR is the significant coverage for the clearance, and about weight, liver type, bilirubin and LT not correlated with the clearance. So they explain is likely due to a disproportionate graft size because the patient usually receive the bigger graft size than their original liver size. So for those that post liver transplant patient, weight-based dosing may be unreliable. So instead of based on the weight, we need to monitor the INR and also hepatic function for the dose adjustment. If let's say the INR is very much prolonged, we need to reduce the Presidex dose. So when Presidex used as a continuous infusion, for patient that critically ill, they notice that the Presidex will move into the third compartment because of the fluid shift and also edema and also the hypertension. So, but uh, when prolonged use, they think the two compartment models best describe the pharmacokinetics during the ICU's care because the peripheral and also deep peripheral compartment will reach equilibrium and effect will be stabilized as compared to the three compartments in the procedure. So meaning when early in the infusion, we may need higher or prolonged infusion to achieve the desired sedation effect because that time they haven't reached the equilibrium. And when the steady state achieved, then the drug will slowly redistribute and there is a risk of the drug accumulation because of the reduced clearance. So some side effect may occur like bradycardia, hypotension, and prolonged sedation. This is more common when in the continuous infusion as compared to the just a uh, short exposure during the procedure. So when patient on prolonged infusion, probably after the patient reach the steady state, the drugs reach the steady state, we need to gradually reduce the dose or even try to off it because of the risk of the drug accumulation. And when used as a continuous infusion, how about the analgesic effect? They conclude that continuous infusion may not consistently reduce the opioid demand. So the first study that they quote was from the Mills. They said some clinical reduction of the opioid use, but not statistically significant. And another study that they quote from Presidex used during the therapeutic hypothermia. They think that a significant opioid reduction in HIE units when used as a first-line sedation and when it used for shivering prevention. This is because this group of patients, they tend to have reduced clearance because of the reduced blood flow, especially in the liver. But Precedex should not be given exclusively just for the opiate reduction in the NICU. Then they compare this study from Song et al. They study about the population pharmacokinetics module of the IV Precedex for the mechanically ventilated patient after neurosurgery. They said there is no difference between high and low infusion doses in sedation score. Both achieve moderate to deep sedation post-surgery. But bear in mind for this group of patients, they are well patients, just electively come in for procedure, and during the procedure, they actually receive some multimodal sedation or analgesia medication. And then subsequently they study about what's this will Precedex affect the hemodynamics stability in the patient. So from this meal study, they used two different doses. Low dose less than 0.5 mic per kg per hour, high dose more than 0.5 mic per kg per hour. There are incidents of hypotension and bradycardia, but it's not statistically significant. And you can see the sample size quite small, just 38 units that they included in this study. Then another study show from the Takuchi, 4.9% patient has hypotension, 11% bradycardia, so no dose response relationship. And from Song et al., also no difference. And from Greenberg, this one also from ICU setting with the 20 infant sample size, no difference in the plasma drug level during the hypotension or stable periods. So when Precedex used as continuous infusion, hemodynamic effects are common, like bradycardia and hypotension, but not clearly dose dependent. Because critical illness itself can confound the heart rate and also blood pressure changes. Degree of hypotension and bradycardia may be depending on the genetic variability at the site of action. So, and interestingly, from this Lin et al., they noticed that delirium risk remains inconsistent, but major determinant would be the patient comorbids. They found that young age patient and those with the high pain score and with the development delay, they are higher risk of developing the delirium. Then in terms of the genomics, man metabolism, as we from previous slide mentioned, they metabolize in liver. Enzyme include UGT2B10 and also UGT1E4. But overall, they said metabolic genetic variants only explain about 5% of the interpatient variability. So that is no need for the genotype-based dose adjustment currently. And also for the target receptors, even there is polymorphism, but they are clinically not relevant. So routine pharmacogenomic studies not recommended for now. Then in after review all the studies, their recommendation would be for neonate and also young infants, because of they have the reduced clearance, so they suggest for the lower Precedex dose. And despite that, we still need to avoid the underdosing infants, because sometimes they may require plasma concentration 1 to 2 nanogram per ml to achieve the adequate sedation effect. And from the reference of the Port et al., those patient less than 6 years old, the dose recommendation is 0.2 to 1.4 mic per kg per hour, and more than 6 years old will be 0.2 to 1 mic per kg per hour, because it's a very wide range. So from this systemic review, they recommend that those that less than 3-year-old should start with the dose of 0.2 to 0.4 mic per kg per hour and titrate up. 3 and more than 3 years old should start with a 0.4 to 0.5 mic per kg per hour and titrate up based on the effect and also tolerance of the patient. So they recommend to use the Dutch PITS formulary to provide, because it provide the age, weight, and target concentration dosing. So for this, for pharmacogenomics and variability factors, they think the variable response is likely due to the multiple non-genetic factors. So that is no recommended genotype-based dosing adjustment required. So for the clinical implication in a special pediatric population, those that post-surgical and also cardiac patient, when combined both Presidex and magnesium, it may reduce the jet incidence, but not AKI. So mixed evidence lah for the cardio and also renal protection. But those patients that post pass because of the larger volume distribution, so this group of patients may need higher dose of the Presidex. And for those that post liver transplant, because of they have the altered pharmacokinetics, then dose reduction advised in the hepatic failure patient. So we should adjust the dose based on the INR and also the sedation score. For HIE patient, because they have the reduced clearance, increase of the medication half-life and delayed time to achieve the Cmax, they may require up to 12 to 24 hours to achieve the Cmax. So for this group of patients, you may need to load the dose or faster titration to achieve the adequate effect. Then subsequently may need to titrate down because of they have the reduced clearance, so may have the prolonged sedation effect. But overall, Presidex provides an effective sedation for HIE units and good in the shivering control and reduce in the opiates use. So conclusion, for pediatric Presidex pharmacokinetics and pharmacodynamics, it's a wide interpatient variability response, but hypotension and bradycardia are not dose dependent. So it's very important that we start with a low dose and then titrate up and closely monitor for the side effect. And Presidex also had the mild analgesic and sparing effect, though it's not consistently demonstrated across the studies. And most reliable predictors of the Presidex pharmacokinetics and response are the weight, age, and also clinical status. For example, like patient with the capillary leak or edematous. And special populations and also type of sedation may influence the dosing needs and also pharmacological pharmacologic behavior. So overall aim of we need to optimize the dosing, minimize the titration, and hope that can reduce the adverse effect. So this is this one is based on the CPS coding. So did the systemic review address a clear focus research question? Yes, it's clear clinical and also pharmacological focus and appropriate for a systemic review. So did the author specifically specify appropriate study design for systemic review to answer the research question? Yes, because inclusion criteria are appropriate to the question. Exclusion of case reports improve the scientific consistency. Then are all the important relevant studies likely to have been included? Yes, but with limitation because they only search the two main database. And sorry. Did the author assess the validity of methodological rigors of the studies in the systemic review? No, because there is no scoring or weighting of the evidence quality. So maybe this is the main downside of this systemic review. So if the result of the study in the systematic review were combined to undertake a meta-analysis, was it reasonable to do so? Yes, because it has the appropriate synthesis method grouping by the pharmacokinetic, pharmacodynamic, and also pharmacogenomic findings. Then section C, what are the results? Have the result of the systemic review been reported comprehensively and interpreted appropriately? Yes, because interpretation are scientifically cautious and clinically relevant. So has any subgroup analysis been designed appropriately and the result interpreted accurately? Yes, but they also do acknowledge the limitation of the data quantity and also study heterogeneity. So did the author reports on how precise the result of the systemic review and the implication can tell it partially but not quantitatively. As an example, like that is they didn't provide the confidence interval. So will the result help locally? Can the result of the systemic review be applied to your local population or in your local context? Yes, because it included the pharmacologic data and also clinical outcome, like what we very interested to know, like sedation adequacy, any incidence of the bradycardia or and also hypertension. Are the benefit worth the harms and costs? Yes, it reinforces the individualized dosing and careful monitoring. So would the experimental intervention provide greater value to the people in your care than any of the existing interventions? Yes, because it Precedex has a favorable safety and sedation profile. So it's a strong clinical relevance and provide insight for our clinical practice in PICU, but has limited database research and no scoring or weighting of the evidence quality. So what is your conclusion? It support the safe and individualized Precedex use. With that, thank you. Any question?
Okay, thanks, Shikin, for the comprehensive review of the Precedex pharmacodynamic, pharmacokinetic, and okay. So, any question?
Thanks, Zikin. Hey, Zikin, can I ask you, so from your paper, does it any recommendation for continuous infusions? And does it mention how long is safe to be used?
Didn't mention about how long safe to use, but their recommended dose is to start with the low dose. For those that less than 3-year-old, 0.2 to 0.4 mic per kg per hour, then titrate up. For more than 3 years old, they actually suggest 0.4 to 0.5 mic per kg per hour and titrate up.
Okay.
But how long to use, they didn't mention.
Okay.
Mm.
How about weaning?
Weaning.
Mm.
No weaning protocol mentioned also.
Okay. Right. Thanks.
Hi, Shikin Lilin here. How about loading? Do we need to load?
It depends on the patient. Because they only mention about those that HIE patient may need loading, but the rest actually didn't specifically mention.
So in your practice, do you load them?
If I want to achieve faster sedation effect, then I will load. But I will load with low dose 0.5 mic per kg.
Okay. How fast you load?
20 minutes.
20 minutes. Okay. So for your experience, how long the infusion that you ever run
How
for?
long?
Yeah.
I didn't really quantify, but some of the patient 3 days, 5 days. Yeah.
Okay.
I see in adults also they use it more than 3 days.
Okay.
Mm.
And how you win?
How we win? We actually reduce the dose. For example, like if patient now 0.8 mic, then we will cut down slowly to 0.6, 0.4. Then at the same time we overlap with the oral clonidine.
How fast is that? Is it within a day or?
If we overlap, then we read it within a day.
Oh, okay.
Yeah.
Thanks.
From the fellows as well, anything to clarify or to ask? So as mentioned by Lilin pula, sorry, Shikin. As mentioned by Shikin, it has been recommended to use Presidex or Dexmedetomidine as first line because of the safety profile and also the risk of delirium being lower. And of course, the things that we want is the natural sleep that we have for all our PICU patients. So hopefully this journal week will help us to understand a bit better on how to use the drug. But of course, not all answers here. Like the question being raised, how to start, how to continue, and how to win is also another topics to understand, but probably not so much being answered in this journal. So if there's no more question, shall we call it a day? I think the next presenter is aware, right? Who is presenting on the next one?
Lydia.
Okay, so Lydia is here, is it?
Mm-hmm.
Lydia is not here, but I suppose she knows that. Huh?
I'm presenting next.
Sorry, who?
Presenting next week. Lydia here.
Oh, Lydia. Okay, you're here. Okay. Oh, you are Hanisa, is it? Your this one?
No, she's with me, Dr. Pon.
Yeah.
Oh, okay.
Yeah.
Okay. Okay. Yep. See you.
Thank you, everyone.
Thank you. Bye.